Good morning, everyone. Today, Gurlal Singh will be presenting the case. It is moderated by Professor Patta Radhakrishna, Professor Jeswanth, and Professor Shabeer Ali. That's all yours. You can take over now.
Morning, sir.
Yeah. Carry
Good morning.
Shall I start, sir?
Please.
on. Gulal, your audio is disturbed. I can't hear. I know whether others can, but
Same here.
no. I think you need to do something about our audio. Yeah, come again. We'll check the voice.
Your voice is not clear.
Yes.
Maybe you can log in, log out, and check. Gurla. Yes.
He's trying to join, sir. 1 minute.
Hello, sir.
Hello.
Yeah.
Sir, I'm audible, sir.
Yeah. Right.
audible.
Perfect.
Yes, sir.
Share your screen.
Yes, sir. My patient is 48.
I think your audio is still having the same problem, I think.
Sir, 1 minute. We have to open video. Yes, video. By connecting instead of phone speaker user.
Ganesh is the standby.
Yes, sir. I'm following him right now.
Sir, I'm audible now, sir.
Yes.
Yes.
Yes, sir. Yes.
Start sharing and go ahead.
Patient.
We are, Gurlal, we are no better. It's the same. I don't know where
So I
the
think we
problem
can go to the
lies.
standby. Next time we can proceed.
So Ganesh, the second person,
He's,
standby.
he's becoming a panelist now, sir.
Who is it? Is Ravi? Is it Ravi?
Yes,
Yeah.
Ravi was the backup. Yes.
Yeah, you can unmute Ravi.
Yes, you stop sharing now.
Ravi, can you unmute?
Unmuting, sir. Am I audible, sir?
Yeah,
Yes.
share the screen. Share your presentation.
Yes. Good morning, everyone. A
Good
40-year-old
morning.
female, a resident of Telangana, came with chief complaints of abdominal pain with fever for the last 5 days. Patient was apparently normal when she developed pain in the right hypochondral region in May 2024, for which she was evaluated elsewhere with ultrasound and diagnosed to have cholelithiasis. She underwent lab cholecystectomy on 23/5/24. On POD1, patient had a yellowish green output from abdominal drain. There is no history of fever, vomiting, or abdominal pain. Patient was managed conservatively with injected antibiotics, allowed diet on POD3, and was discharged with abdominal pain in situ, draining around 200 to 300 ml of fluid per day on POD7. And the operative duration was 2 hours with 100 to 150 ml bleeding during surgery as told by the surgeon. There is no detailed notes available. Post-discharge, she presented to a tertiary hospital with complaints of pain and abdomen fever. I wanted to know if there is any during this referral to the hospital. Did she have any fever with chills and rigor? Any history of jaundice, pruritus, or change in stool color during that time? And is there any information available on what was done at that time? And how was that? Was the drain present or removed? And what was the kind of fluid coming in the drain during that time? And also, I would like to know any other complaints in this last 6 months. She had intermittent dull aching pain, mild pain in the epigastric region related to the back, not related to meals, which is related to oral analgesics since the last 5 days. She also had complaint of intermittent low-grade fever, noticed with chills and rigor, and history of loss of appetite and generalized weakness was present. As there was no history of whether drain was removed or not, I wanted to know, I assume that there is a drain still present, and I want to know there is recent change in drain output, and also want to know any history of weight loss and any history of steatorrhea or fat soluble vitamin deficiencies. And there was no history of any abdominal distension, vomiting, passing any clay colored stools, itching, hematemesis, melena, postural dizziness, syncope, fatigue, shortness of breath. There is no history of any blood transfusions. The histological review of specimen was chronic cholecystitis. Coming to past history, there is no history of any comorbid.
Ravi, just what is your impression from the history in this patient?
I was of the impression that there is a bile duct injury. It was a difficult lab cholecystectomy, and there is since there is bile leak from day one, and I suspect there is a bile duct injury.
Okay. Before that, I'll ask you one thing. Forget about the post-operative events. In a patient who underwent a cholecystectomy, is it relevant to ask what was the preoperative symptoms in detail?
Yes, sir.
And what is the importance?
It is relevant.
They are just giving the history as a right hypochondriac pain, and somebody has done an ultrasound and they found out gallstones and underwent cholecystectomy. In this current era, is it still relevant to ask a detailed history? What was the symptoms? All those things.
Yes, sir. It might be of some use because if she was having recurrent episodes of pain, she might be having chronic cholecystitis, or if she had any fever or any such symptoms, we could make acute cholecystitis, both of which are conditions are quite difficult to operate.
Apart from that, how will you ask for the history, that preoperative history?
Sir,
The patient is coming to you after the surgery. They have given the history just as a right hypochondriac pain.
yes, sir. So, sir, whether to
One, as you said, I understand that was correct what you said, like whether the patient had cholecystitis or any cholangitis history or any chance of having a difficult coli. Anything else? The relevance of asking the correct history, details of pain.
like I think for I think in terms of difficult surgery, I think the history would be helpful.
Ravi, I mean, your history is a bit jumbled. It is not as smooth as it should be. Then in between you use language like "I would like to know," "I would like to know." Those I mean sentences generally don't come in presentation. You should say there's no history, or there's I mean no such history is obtained. Maybe because you're woken up to present that you're a bit jumbled, but that should be a lot. And I don't get a proper sequence. Now, if you finish this personal history and then you summarize the whole history in about 4 sentences.
Yes.
Because there's a lot of gaps, as Dr. Shabeer says. We want to know what was the pre-op status, what are the relevant symptoms. Does imaging suggest anything that the surgery is going to be difficult in the future, and so on?
Sir.
Yeah, come back again.
Yes.
But you need to have a perfect history.
This was sir. Coming to past history. Can I continue, sir?
Yeah,
Yeah, give us
yes.
a short summary of history of whatever has happened us, and then we proceed.
Yes, sir. There is no history of any comets in the past history, no family history, and personal history, sleep apnea normal, bowel blood problems normal, mixed data, no addiction, sir. So coming to summary, sir, a 48-year-old female post-lampulcystic female 23 to 24 for symptomatic cholelithiasis with bile leaks since POD1 from the abdominal train, which was managed conservatively and discharged with train in situ, with training around 200 to 300 ml per fluid per day on POD7. Now came with intermittent dull aching, mild abdominal pain in epigastric region, radiating to back, and intermittent low-grade fever not associated with chills since 5 days, along with history of loss of appetite and generalized weakness. My tentative diagnosis would be a bile duct injury with secondary symptom with acute pancreatitis.
Now, see, this history has got 2 segments. One history is previous surgery, and second history is what she's presenting with now. Do you think the sequence of events are proper or anything improper?
Excuse me, sir. In the history, she presented 3 weeks after discharge to the tertiary care center, not at present.
Yeah. So if you had to ask, you want to know more history about the past presentation and imaging, and also what had happened in the operation room and why was a drain put. Can you explain a little more in detail? And whether they were right in discharging with patient draining bile up to 100 cc's?
Probably the day one drain output would have been high and it had come down gradually to 200 ml. Maybe that's why they have discharged. But I don't think it is right to discharge with the drain still and not doing any intervention. Without doing any intervention and with the drain being around 200 to 300 ml, I don't think it's good to discharge. It is not a good point to discharge POD7, sir.
And patient is symptomatic with continuing pain.
No, sir. The pain was for the last 5 days, sir. At the time of discharge, she was fine. She was having only drain.
High drain output.
Yes, sir. But after 2 weeks after that, she was referred to a tertiary care center where she came to with pain. Then after 3 weeks, she came to another tertiary care center with pain and abdomen. But there was no history about what happened over there.
So if you are the surgeon and this is a situation of 200 cc, on the day 1, day 2, will you discharge the patient, or what will you do? What all things would you do?
I wouldn't discharge the patient. I wouldn't discharge the patient, sir.
Okay.
I would serially monitor the drain output. I would note whether there is any decreasing trend of the drain output, whether the patient is passing colic or acolic stools, and whether despite being drained, does the patient have any fever. So if she had any other fever or any additional pain or any signs of peritonitis, I would do an ultrasound abdomen or to look for any undrained collections.
Wouldn't you try to find out where is this leaking from?
Yes, sir. If the patient had colic stools, I would wait a bit longer for the drain to settle. If the patient is having acolic stools,
Is stool color that important to decide on what to do in terms of imaging?
Yes, sir. Because if it is a type A and type D injury, the patient will be having will having colic stools. I could do a ERCP stenting, which will help in reducing the drain output, sir.
Will you straight away, in this situation, the patient is having 300 ml drain on day 7 and some epigastric pain, will you straight away go for an ERCP?
No, sir. I would wait. I would wait, sir. I would wait till the patient is pain free. And the
will you do a CT scan at this stage? Patient is having continuing pain, dull aching pain.
Yes, sir. Yes, sir. First, I would do ultrasound. Yes, sir. I would do it if the ultrasound was not informative of any other collections and not properly informative. I would definitely do a proper CT scan, sir.
And then what will you do?
And if there are any undrained collections, I would drain the collection. I would put additional drains to clear off all any other collections.
Okay.
And because it's been 7 days, there is operating. I would prefer a delayed operative intervention in such cases rather than jumping into a surgery.
Okay. So you did a CT, no undrained collections.
Yes, sir.
But drain is still 300 on day 7, and it's not coming down.
That's what, sir. If the page, if I'm sure that there is biliary continuity, I would just do a stenting. If there is no biliary continuity, if the CBD itself is clipped off, I would just wait and watch, sir. Manage the patient conservatively for at least next 3
How do you
months.
know that? How will you find out there is biliary continuity?
Sir, by looking at a stools, sir.
Only at stools.
How often have you done this, Ravi? How often have in your clinical practice or where you work that people depended on the color of the stool to say whether the bile duct is clipped across or not? See, in other words, what Dr. Shabeer is trying to say is that before the patient leaves the hospital, we should know what is the nature of the injury, whether the patient can go home and then we can wait, or whether something needs to be done. Actually, if you really, we don't have the history, but looks like such an attempt is not done. So what exactly is the attempt you do to ascertain the nature of leak, the nature of injury before, sending the patient home?
If the patient is pain-free, I could do an ERCP, sir. I could do an outright, even without looking at the stools, I could try an ERCP stenting.
Will an MRCP help instead?
MRCP, sir. With that much inflammation, I don't think MRCP is going to be that informative. Would wait.
Is it MRCP has to do with inflammation or the collection around?
Even collections will affect the MRCP, sir. But as I told that
how does inflammation affect MRCP?
because MRCP is a T2 weighted and inflammation is also fluid, like fluid correction. I assume that MRCP might not be helpful.
Now, isn't MRCP the first investigation you do in this patient
No, sir, I don't.
before anything else?
No,
Huh?
sir, I would do an ultrasound.
How does ultrasound tell you where is the injury? Whether it is a slipped cystic duct clip or a lateral injury or a tied up, how will you know? Yeah, see, thing is, I mean, in this, but this is a very common situation. In the common operation, all the complications are not common. But if ultrasound you do only for the collection to be drained. My question is, you need to ascertain where is the injury, what is the nature of the injury.
Sir,
yeah.
Sir, I would do, sir. I think I would do an ERCP, sir. MRCP.
What's wrong with MRCP?
There's nothing wrong.
Yes.
MRCP non-invasive readily available, give more information, no?
Yes, sir.
No, Ravi, there should be hesitation. Of course, if there's a lot of fluid, there may be an issue, but otherwise, it will tell it is a very sort of slipped clip or a tear or a tie, whatever. We have some idea because patient can't go home without knowing what is the cause for, the bile leak.
Yes, sir, I would at least wait another week to to do an MRCP. I won't do right away on day 7. So that's what I was. Day 7, I wouldn't do, sir.
What is the day 7 business for? What has MRCP got to do with duration? Is there any correlation to that?
No,
How
sir.
does inflammation affect MRCP?
Still
I don't know, but maybe you won't have come across any of the situations, but the first thing is a non-invasive investigation. ERCP you do when you have some idea what is the nature of the injury, and especially if you're going to intervene and do some intervention.
Yes, sir.
Right. Jeswanth, you're saying something.
No. Since being the surgeon, she should act proactively. So you can review the beautiful record, whatever injury, the character's injury, whether it's left CBD stones. So everything will decide. No, you should decide.
Yes,
Early, so I go for early surgery, late surgery.
Yes, sir.
See, Ravi, you should understand that when this patient, the history matters a lot because there is very little on clinical examination where you can make out anything. You should go little more into detail the history as to, preoperatively was some difficulty in surgery anticipated, and we need to know a little more details during surgery, why a drain was put. You said there's some blood and, and then we also will have an idea when you image subsequently, as to the collection and the number of clips and location and all that. You'll have some idea. So you need to focus a lot more on the history, and history in itself. You can find out what are all the gaps in the treatment that is given. This itself has to, give an impression that you have gone thoroughly, you have an idea of everything. Again, the thing of MRCP, I don't know why you are hesitant, but then MRCP is one of the initial investigations to see where exactly the bile duct is injured. Shabeer.
Hello, am I audible?
Yes.
Yeah.
Okay. Yeah. Definitely, we should do an MRCP at this stage. That's what I was meaning to say. Somehow, how I got logged out.
Yes.
So,
Non-invasive investigation you should do first.
Okay, go ahead. Yeah. You're saying something, Ravi?
Nothing, sir. Shall I continue, sir?
Yeah.
So why you put the diagnosis as a CBD stone there? But
Well, she's having intermittent pain.
pain can
And
only be
Sir.
Will it lead on to a diagnosis of CBD stone?
CBD stone as a causative agent for a leak in terms of cystic duct leak or something. See, the second thing is you put a pancreatitis, acute pancreatitis. Actually, you're getting into more trouble there. When it is bile duct injury, when you add a stone and acute pancreatitis, then you'll get into more trouble, and it's very difficult to get out of it. Yeah, sorry, Shabeer.
Why can't it be just cholangitis, the pain? There's a CBD injury, you have a leak.
Yes, sir.
Or some undrained collection, no? Why you suspected a CBD stone? Is there anything strong to suspect a CBD stone?
Because further in the examination, sir, the patient still has drain.
Not
and,
further in the exam. You are giving a summary after the history.
Sir.
So you should give the possibilities as per the history.
Yes, sir.
So from the history, it is only a external biliary fistula.
Yes, sir.
Isn't it? Patient even doesn't have a jaundice clinically noticed.
Clinical doesn't have jaundice, sir, but despite 6 months after surgery, she is still having persistent drain output, and there is no history of any like ecolic stools. I feel like there had been some CBD stone which has completely blocking the ampulla now, which led to because
then how can you get? You are saying there is no ecolic stools, and if the CBD is completely blocked.
It's sir. I'm not saying it's completely blocked, sir. Patient is having pain related to the back, sir. So that's why I suspected acute pancreatitis.
Acute pancreatitis due to?
Sir?
Due to what?
Due to a CBD stone, sir.
Oh, means CBD stone was there earlier, it has come to the ampulla and blocked it now. And that is the cause for pain. And this is a bit far-fetched. I think that is not a very acceptable explanation. Pain can be due to many things, but calling it pancreatitis due to stone, bringing a stone itself is dicey here, very difficult to defend. And then on top of it, if you say pancreatitis is a lot more. So if that is the suspicion, how will you proceed in case? Anyway, we'll come to that later. Just complete the examination.
Sir. An examination, patient is conscious, cooperative, well-oriented. Patient is moderately built and nourished. Her height is 150 centimeters, weight is 40 kg, BMI 16.8. Breath volume time is 35. She has pallor. No evidence of victorious sinus, clubbing, pedal edema, lymphadenopathy. She is febrile. Pulse is 96 beats per minute, BP 160, and respiratory is 15 per minute. On inspection, abdomen is flat, umbilicus central inverted. All partners move equally with respiration. Healthy primary heel ports, right scars. Abdominal drain in the right flank draining around the yellowish green content of 200 ml. No peristaltic sinus engorged veins. No flank fullness. Anal orifices and genital appear normal. Radial angle appear normal. Inspectory findings confirmed. Tenderness present in the right hypochondrial epigastric region. Liver and spleen not palpable. No palpable lumps. Percussion, liver dozens in the fifth intercostal space. Liver span 14 centimeters. And flanks at tympanic set. Auscultation, normal bones insert. Distal examination, normal sphincter tone, gland stained with normal feces, no clay colored stools. Respiratory, normal vascular breath zone, pyrethroid airway and equal, no crepitation added zone, CVS SNS2 normal, CNS higher mental function normal. 48-year-old female post lateral cystectomy on May 23rd. For symptomatic cholelithiasis with bile leaks in POD1 from abdominal drain, which was managed conservatively and discharged with abdominal drain in situ, draining around 200 ml per day on day 7. Now came with intermittent dull aching pain, mild abdominal pain, epigastric region radiating to the back, and intermittent low-grade fever, which is not associated with any chills since 5 days, along with the history of loss of appetite and generalized weakness. On examination, patient is moderately nourished and had pallor, with drain in situ, no signs of liver cell failure, and there is tenderness in the right hypochondriac region, epigastric regions. This point I would think it's a case of bile duct injury with persistent biliary fistula with bilioma, the new collections.
Why you suspect a new bilioma diagnosis there at
Because
this point of time? This is 6 months after surgery.
but still she even now she was having some persistent fistula, sir.
What made you to think that there is a bilioma? Your first diagnosis is okay, bile duct injury with persistent biliary fistula, and you wrote a diagnosis of bilioma. What point from the history made you to write a bilioma at 6 months time?
On palpation, sudden onset fever, sir. On palpation, there is tenderness in right hypochondrium. So I suspected a newer collection.
At 6 months, is it common to have a collection for a patient who has a controlled biliary fistula for 6 months and suddenly develop at 6 months?
I don't have a proper history of what happened the last 6 months, sir. So
This is 1
Okay,
month
forget
after
whatever
surgery
is
only.
available to you. This much history is available to you. Now the patient is presenting with fever and right hypochondriac pain. Is that what you're saying now from the history? Whatever is available to you. And what is your diagnosis? A patient with a controlled external fistula, 6 months now from the primary surgery, and now there is a new onset fever and right hypochondriac pain. What does it suggest? What will be your first diagnosis?
new onset pain, sir.
Isn't it possible to have few more collections which been asymptomatic all the while and they got infected, where patient presenting with pain and fever? I mean, it actually drains, don't always drain the entire area. Sometimes, actually, one of the commonest things will be, a collection. Right. Okay. But then, the second diagnosis of CBD stone and pancreatitis is a lot far-fetched. So that is something which is not acceptable as a different diagnosis. And if at all, because you should be able to explain what is the mechanism and so on. That is not in place. Now, so this is your present diagnosis, the primary diagnosis of bile duct injury, person biliary fistula, bilioma. Okay, patient has come to you. How do you proceed?
Yes, sir. I would order routine I would order complete blood picture along with LFTs and RFTs along with an ultrasound of abdomen, sir. I would.
You have all the reports.
You want the basic labs now, current.
First, you want the basic labs. Hemoglobin is of 8.5, total counts 20,900 and platelets at 5.6 lakhs. LFTs.
What does it suggest? This from the
patient is having acute infection.
What infection?
Probably cholangitis.
From total count, platelets, and that hemoglobin, what does it suggest?
Platelets are elevated, sir. Hemoglobin is decreased.
What is more prominent is the total count.
Yes, sir.
So he has some acute infection, and what does that hemoglobin suggest?
She's having deficiency. Some deficiency. She's nutritionally impaired. That's why she's having lower hemoglobin.
Is nutrition more probable, or is some ongoing sepsis for last few months is more probable?
Now, if I ask you, Ravi, can you give 3 reasons why the hemoglobin is low?
One thing is like she's there is history of loss of she's having generalized
weakness, surgery.
No, sir, not she's having generalized weakness. Probably she's one cause I think she is nutritional deficient, sir. And
I mean, nutritionally deficient. See, how would I answer? general Indian woman population, whom hemoglobin can be low, I'll go back to the preoperative hemoglobin and check whether there's any difference. Whether it is 9 or 10 earlier and 8.5 now. Then the second thing is there's some blood loss at the time of the surgery. Sometimes the assessment may not be improper, because another point we didn't really get back to you is whether you suspect it's just a simple bile duct injury or there's some vascular injury as well. And nutritional thing is a possibility, but that will come much, much lower down. And as Dr. Shabeer says, infection in itself will, decrease the hemoglobin. I mean, a question has to be answered in a very methodical way. Yes.
Yes, go ahead.
LFTs. Patient has a total bilirubin of 1.5, direct 4.8. SCOT, SGPT, my ALP, there is mild elevation, sir. GGT was not mentioned. Albumin is quite low, so 3.4. The INR is elevated, 2.26.
What does it suggest? Elevated INR.
She's having some vitamin K deficiency, sir.
Why?
Probably due to loss of fatty acids, but due to loss of bile, she would be having some fatty acid deficiency, which is essential for absorption of vitamin K, which is a fat soluble, fat dependent vitamins.
Why can't it be due to some hepatic dysfunction from a biliary stricture? And how can you differentiate? 6 months now, no, from the injury.
Yes, yes. It can be due to liver deficiency also, because albumin is quite low. The synthetic function of the liver has come down because albumin is also low.
So how will you differentiate the two? Your two probabilities.
Yes, sir. If it is purely a fatty acid deficiency, the bilirubin won't be elevated. But if it's a liver issue, the bilirubin will be elevated.
Okay, the bilirubin and direct bilirubin together, what does it suggest? The first two columns.
Direct bilirubin doesn't suggest too much of the
Actually, they together do not suggest much actually. Because patient has got a fistula and bile is draining out. SGOT, SGPT, what do they suggest?
They're normal, sir. But,
so there is no sort of cholangitis, because that is your suspicion for quite a while. And Shabeer also is wondering whether it's there. ALK first, what does it suggest?
Mildly elevated, sir. 120.
So there is some element of obstruction, to the bile flow. What does albumin suggest?
Albumin, there is some synthetic deficiency from the side of.
I don't know. I will check with the preoperative albumin and only comment on it. Because 3.4 is not a bad albumin, actually. And if our preoperative albumin is only that much, there's no big deal. If it isn't so, then I'll think that there is some fall in the liver function, synthetic liver function. And that is evidenced by the last column. What does it say?
INR elevated, 2.26.
So there is some subtle liver dysfunction, is what it suggests. Why are these things important? What is the significance I left in this patient?
Because if the stricture might cause a secondary biliary cirrhosis, we need to rule that out too.
So these have a significance. One is in diagnosis of the condition, diagnosis of liver function, and recovery. In the post-operative period, I'm worried about INR. 2.26 is not a good INR to do things, and we need to correct it.
You give vitamin K and then C. Yeah, if it is responding, it is unlikely to be a liver dysfunction.
So every number has got a significance in this patient. Okay, go ahead.
RFTs. Blood urea is 29, sir. Creat 0.73. Electrolytes are 139, 4.3, 100 normals. I would go for an ultrasound abdomen.
Okay.
Sir, I would also do a MLS and lipase because I was suspecting pancreatitis.
Oh, you're still on it. Okay. Okay.
Okay, next.
What is MLS lipase show? Did you do it? No. Okay, next.
Ultrasound abdomen. Ultrasound of abdomen. First is that if the preoperative ultrasound is available. Liver is normal in texture. Well different, well distinct. Multiple calculate large number.
So what does this ultrasound suggest? That
It was not a case of acute cholecystitis.
yeah. So it shouldn't be a difficult cholecystectomy by any means. Right.
Now I want to know the present ultrasounds. Liver is normal. There is a collection in the gallbladder fossa extending to the perihepatic epigastric, drain tube in the GB fossa. Pancreas normal.
I mean, is this a good report? Mild collection gallbladder fossa is something which we very routinely see, especially when you operate on acute cholecystitis. Extending into perihepatic and epigastric region. What more we would like to know about this? I would like to know whether that is the cause for pain. So will you know that? They need to quantify it, the size and the volume is something which in case you are the treating physician, you would like to know from the phonologist as to how significant is it, because mild collection gallbladder fossa that is extending to it doesn't sound very very nice. Yeah, what next? Based on this, what will you do? What is your opinion? What do you do?
Is it during the immediate post-op or recent ultrasound?
Immediate post-op.
Immediate post-op. This ultrasound immediate post-op or recent ultrasound?
This is 3 weeks after surgery when she came to the hospital.
Right.
Okay. Okay, based on this, do we proceed further?
So I want a present ultrasound, recent ultrasound.
Is this not the recent ultrasound?
This is not the recent. This is 3 weeks
Okay,
after surgery.
you have one more report? Yeah, please show.
This was the ultrasound with the presentation.
At presentation, yeah. Okay, Ravi, you have LFTs, you have ultrasound. Have you made your diagnosis and treatment plan?
No, sir, I would do a CT, sir. This isn't informative. I would.
What are you looking for in CT?
Any undrained collections?
Okay, CT. Is CT a very good investigation to show us the biliary tree and the injury, the level of injury, and so on?
So this patient has collection, maybe that required the CT scan first.
Yes, sir. But for biliary tree, I would prefer an MRCP, sir, rather than the CT.
When will you do the MRI? If you have a collection in the subhepatic region, they already mentioned a collection.
Epigastric region also, no?
Epigastric region. Will you go for a CT straight MRI or a CT at that stage?
I would go for a CT, sir. CT, look for any
And
other.
then?
And then if any collection, any other cultures, I would drain it off. Then would go
and
for.
Then
would go for an MRI, sir.
Okay. Is that? What will you see on the MRI? Anyway, let them load it.
Sir?
What all things will you see?
I look for stricture, level of the stricture by biliary tract dilation. And the look for any atrophy hypertrophy complexes.
Okay.
In MRI or in CT?
Even MRI gives picture about crowding of the ducts. Give him like
Yeah, can it? What
can point
else?
to the atrophy of liver cell.
What else?
If it's a contrast, I would contrast and MRI. It would give some information about the vascularity also. It gives information about any vascular injury.
Hmm. Okay, you have the pictures.
Yes, sir.
How much is the bile draining now at this juncture? 200.
I said 200.
So what's happening to the rest of the bile?
There can be some internal fish.
Okay.
What do you mean internal fistula?
It can be the colidoc because it's a colidoco. Maybe there is not complete stricture. There is some part of CVT patient which is training, or a colidoco-duodenal colidoco-gastric fistula might have been formed due to pressure from the connections.
Okay. So we can't design the treatment until we have a proper imaging of what the biliary is like. Like say if the
Do we
patient
have
has
a
got,
report if images are not available?
say there are two collections, one in the epigastrium and the right hypochondrium. What do you do? How do you start the treatment?
I would go for an ultrasound-based drainage of the collection, sir,
Why?
because I would like to do an MRCP. So I would like to keep the field dry for a
Is
proper
that the
MRCP.
reason?
And that too, if patient is in fever, she's having acute infection. That also helps in. It's like also a therapeutic point of view. It would set the infections.
Now, anyway, you want to go in and operate in case based on the reports. Can't you sort of take care of the collections at that point? Why do you want to do it beforehand? Why do you want to drain them?
I would like to optimize the patient before going for a surgery. I would like to have to be improve our like INR. Even albumin. Albumin is low. If we are going to do an operation, it would be a hepatocytostomy. And within such low albumin, I don't think it is not. It is. There
Is
are
this
less
albumin a
distances.
contraindication for surgery?
It's not a
Would you like to
contraindication.
improve the albumin?
Yes, sir, I would prefer improvement of the albumin because FJ
3.4 is not a bad albumin. You don't try to improve albumin at that level. For an Indian, that is fair enough. Okay, read the MRI. What does it show? For the MRI, 3.4 is a near normal albumin. See?
This.
Now, what is the cause for the pain, epigastrium, back pain?
the collection irritating the peritoneum might be one of the causes for pain, sir.
Why do you say one of the causes? That should be the cause.
That should be a cause.
So there is no suggestion of pancreatitis, no suggestion of bile duct stones. Your second diagnosis is ruled out. biliary tree, can you comment on the MRCP? One thing we can notice is that there's not dilated.
But not much IHPR is there, but there is still some collection in the epicus until to the levers.
Now, see, Ravi, you are commenting on albumin to improve nutrition. What would be the optimal albumin you are aiming at?
3.5 and above, sir.
What is the difference between 3.4 and 3.5?
Yes, sir.
You know what albumin level you want any anastomosis?
3.5 and above, sir.
You want any anastomosis?
If it is 3.1 and above, it would be an anastomosis.
So below 3.5, sir, you want to any anastomosis.
Sir, below
You want
3.5.
any anastomosis if the albumin is below 3.5.
Yes, sir. Wouldn't do it.
How will you improve the albumin?
First of all, once the infection is patient is having a high count, she's an acute infection. I would give some antibiotics, drain the collection, give antibiotics, let the infection to settle. That itself can reduce because albumin is an acute phase reactant. There is in acute infection, the albumin usually forms.
Yes.
So
Then
once the infection
yes.
like settles, I think
Yes.
I will pick up
Yes.
and I would.
Next. Patient loss of appetite, improve nutrition, and make the patient walk also. Physical activity is very, very important. Physical activity is the single most important stimulus for liver.
Yes, sir.
Nutrition, controlling sepsis, physical activity, all these things will improve albumin level. So,
Okay, what is the diagnosis on MRCP as far as the biliary tract is
It
concerned?
doesn't. Yes, sir. No.
Yeah.
Can I have a proper MRCP? I'm not able to find the MRCP.
So, if you, on MRCP, you're not able to decide the level of injury, and you can't plan how to proceed further, then what do you do?
I have a drain in place, sir. I would do a fluoroscopy. It might give some idea of the stress tracts.
Do you have that? And how often has that been done in your experience? Is it commonly done?
But I couldn't. I wanted a proper T to MRCP image. I couldn't find that. I would
What is the most important point you want to see on MRC in this patient regarding the bile duct?
So, how far is it from the hilum?
You can see the hilum, you see both ducts communicating. So it's not a hilar injury. You have, for that matter, a little more duct below it. So are you happy about it that it's low down below the bifurcation? Right. Now, so we understand that the whatever injury is low down. Is there
Here
any
you have a
suggestion?
controlled biliary fistula without much of biliary obstruction and cholangitis. So what is the thing you are looking at in MRC in a decision-making perspective?
I would where exactly the injury is.
Is it the location matters or something else? You are repeatedly saying you will look at the clinical parameter to see that.
Not clinical parameters. In MRCP, I would like to see where exactly the injury is. Whether the distal.
Whether there is a continuity or not,
See,
that is
Ravi,
the most important. No? You are always saying you will see the color of stools to take a decision on that.
Not that.
Ravi, are you happy with the
Here you have a
MRCP?
controlled fistula lasting for.
Yeah, that the ducts are not dilated. You would love to have dilated ducts or undilated ducts like this, which is more a happier situation for you as a surgeon to decide on what to do further.
I would like to have a dilated ductal system there, so that anastomosis would be, and even if undilated, we can extend the incision. We could extend.
So this is a patient who's got a collection retrogastric and the ducts are not dilated. Looks like whatever injury is below the bifurcation. What would you do now? Would you plan for something immediate, or would you plan for something little later?
Yes, sir. I would wait for the ducts to dilate.
How long? So the other examiners agree with that, Dr. Shabeer, and just that he want to wait.
What is the situation now? You have a patient 6 months from cholecystectomy, still having a 200 ml bile outside coming out. What do you want to do for that? That is the main issue for the patient now. No, there are some controlled collections here and there, 1 or 2 small pockets. But basically, an external biliary fistula is the main problem, which is not resolving for 6 months.
One option is that
What are you going to do for that? You are happy with it? 200 ml for 6 months. Patient that just had a simple cholecystectomy.
No, sir, I'm not happy with that. One thing we can try is
You want to do something, or you want to wait?
Because the fistula is training well, you can do a fistula jejnostomy, through a fistula jejnostomy.
You go for a fistula jejnostomy in this situation.
No, once the infection settles,
Ravi, have you heard of a fistulojejanostomy in biliary duct, bile duct injuries? Ever?
I've read up.
Fistulojejanostomy is more of a pancreatic issue, not a
No, sir,
biliary. That's a risky thing to say.
If the bile duct is
Have you ever heard of a fistulojejanostomy in treating bile duct injuries? That's not a.
I read about it, sir, but I haven't seen it. I've read about it.
In rarest of rare circumstances, I will do.
Yes, sir. But because it is continuously training, I don't think there is chance that the bile duct will dilate.
Ducts are there. You want to left duct, right duct, intraabdominal dilate. Is there any continuity of the bile duct? Would you do fistulogram?
Yes, sir. I asked for
Characterize
fistulogram.
better.
I asked for fistulogram, sir, but the image wasn't available, I think.
So there is a situation where the ducts will not dilate.
Yes, sir.
What is that? And how do you deal with it? There is a condition called primary sclerosing cholangitis, and there's yet another condition.
Yes, sir.
What is it?
It's a inflammatory condition with multiple strictures and with intermittent dilatations along the biliary artery, sir.
So there's something called secondary sclerosing cholangitis. If patient has secondary sclerosing cholangitis, the ducts may not dilate, and if they do not dilate, then we are in trouble.
But there should be multiple stones along the biliary artery,
That is primary sclerosing cholangitis. The stone disease will not. You see, you're very fond of stones for some reason. We shouldn't bring in stones in this particular patient at all. If there's a question like that, you should be able to answer, because the ducts are they look normal. There's no any suggestion of, and they are not a very ideal things for any anastomosis. As a matter of fact, we need to still wait for the ducts to dilate, and they do. Actually, you can wait longer, provided you control sepsis and so on. So,
will you try any endoscopic intervention at this stage? If the MR is showing some doubtful continuity, or is it too late to attempt an endoscopy?
One thing I want to request is
6 months with a 200 ml external biliary drainage.
I want an MRCP image.
MR report you want to see?
Image, sir. MRCP, sir. They have shown me MRCP. 3D reconstruction of the biliary artery I want to see.
See the report again, MRI.
Report, I want to see the image, sir. Then,
what does it say?
3D reconstruction images were not with the patient.
Okay.
Okay, what now? What? You just give a final treatment solution now.
Right. CPD normal. I would do an ERCP, sir, once. I would.
What?
There is no mention whether regarding any stricture was. You try to do an ERCP.
Okay, you have a report, ERCP report?
Next.
On the CPD candidate mildly directed cutoff at CHD with clips at CHD level. Let's spectrum to be done.
So what will you do now? 6 months post lab coli with minimal centralized dilatation with biliary fistula.
There is cutoff at CHD, sir.
Yes.
So continuity. Either we should, because it is continuously draining, I don't think the ducts are going to dilate. Once the infection settles, I think it would be a better option to operate. And even if it is not that dilated, I would incise longitudinally over the CPD with extension of the left hepatic duct, because that seems to be a bit dilated. I would do a longer hepatic jesnostomy.
So we cannot keep on waiting also. It is unlikely to dilate also.
That's why I would do a settle the infection, improve the coagulation parameters, then would plan for a hepatic jesnostomy, sir.
Go to the next slide. You're showing something. See, you need to have reasonable expertise to go in straight away and do with these smaller ducts. At your level, I'll be glad if you say that I'll wait for some more time, at least 3 more months, and take care of the collection and sort of improve nutrition and take a call at that point of time. Shabeer?
Yeah, Ravi, when you're waiting, no, what are the points you see? What are the alarm signs that you want to do earlier?
She's having recurrent cholangitis.
Okay.
Where is cholangitis? Where is the proof?
There is no cholangitis in this patient.
Okay. Now, if you are waiting further, what all things will you monitor?
I would monitor liver function, sir.
Okay.
And
Hello.
And nutritional status.
Hello.
Okay.
RFTs, because there is loss of bile, I would keep a look on the renal function test, creatinine as well as electrolytes, because they are prone to AKI because of lung loss.
Okay. How do you monitor for biliary cirrhosis? That is your worry, no, when you wait longer.
The left is
Or what are the risk factors for developing a biliary cirrhosis in the present clinical presentation? Will she develop a biliary cirrhosis if you wait, or she will not?
Because by this training, I don't think she is at risk of biliary cirrhosis. There is no obstructive biliopathy as such, which will
Can't be sure of that. As has been suggested, it looks like the common hepatic duct is not completely clipped. It looks like a partial clipping, because when ERCP is done, the contrast went into the proximal biliary tree. And if biliary sphincterotomy is done, in addition, anything else more could be done in this patient? In a patient who is partially clipped bile duct?
ERCP image, sir. I didn't. ERCP, they told CHT clipped off, no, sir.
Is absolute completely? If that is so, when you do a ERCP, the contrast will not go any further up.
Image, I haven't. Image of the ERCP.
Just get back to the ERCP once again.
Is there any ERCP image available?
Sir, ERCP images are not there, and
Yeah.
MRCP
again.
was done afterwards also.
So without a clear CBD picture, I would like to have an image of.
Danesh, can you show the current MRCP picture,
Yeah,
reconstructed image?
yes, sir. Recent MRCP images.
So that was 3 months previously done, huh? That MRCP.
Yes, sir.
Previous one
This
was 3
is
months. That is when he presented with collections.
Okay, right.
Then
Not
When it was
PCD
drained,
and now
after that 3 months, patient has come for
Right.
a definitive procedure.
Okay.
So can you show the MRCP, current MRCP?
this one is the current.
Okay.
There's a cutoff there.
So there is cutoff near the
Yeah,
height.
and actually, frankly, it's reasonably dilated for a
Yes.
surgical intervention, because this image we couldn't see earlier. This is reasonably dilated to go. What procedure will you do here in this patient?
RY epidiostomy with extension onto the left appendix. Because hilum is too short, I would like to extend the incision of the bile duct onto the left side.
There seems to be another separate duct to the side. You can see there. You know, that you have to have a closer look before, because may require another anastomosis there. Yeah. So I don't know, Ravi. I think you've been woken up from sleep to present. So you not put your thoughts together. It could be a lot more organized, starting from the history, and put it in a much smoother way. And then you're a little hesitant to do MRCP from time to time, which is something which is not so acceptable, because you say ultrasound then go to CT. We can't have too many investigations. I don't know why the MRCP thing wasn't discussed much. Again, I think you need to go a little more, have a closer look and form proper thoughts about it, Ravi. Shabeer?
Yes, yeah. I think you discussed reasonably well, but some areas there was some confusion. As being a standby presenter, no, without preparation he came in, but still he presented reasonably well. But some areas like this wet strictures, how to go about, he needs some more clarification.
And because this is one of the simpler cases in a MCH DNB to discuss, because you can't falter. Yes.
Yeah, little bit confused. But on table, what will you do if you're not able to do anything? Get expert or refer to expert, put a drain and do it later, or immediate surgery is possible. Or in biliovascular injury, you do later. The clear-cut bile duct injury, the earlier surgery is also one of the options. Whenever there is collection, you drain it. And after 3 to 4 weeks, you plan surgery if everything is all right. You cannot keep on waiting for a long time also. They'll go for biliary. These are basic concepts. And early structural continuity, ERCP dilatation, multiple stents with repeated stent is also a very good possibility. And surgery, of course, you time the surgery, late surgery means. And regarding albumin, see, you can do even below 2.8 also you can do, but of course not less than 2.8, 2.8 you can do, but of course there's slightly increased risk, but you cannot keep on doing that like 3.4. I will not do that down all. Of course, less than 2, you will definitely any anastomosis will leak. But the cutoff is around 2.8 to 3, reasonably good. So how to improve the albumin is nutrition, control the sepsis, physical activity, precautions are very, very important. And you plan surgery.
Back to you, Pradeep.
Whenever a patient referred to, you get all the information. If possible, review the video also. That's the most important thing. Then you get an idea. Assess the patient as you go. MRC is being non-invasive, you can be little liberal. Of course, when there is collection, you have to need to do CT scan. But bile can be also, early bile can be also from duodenal injury also. Keep in mind, bowel injury also. Not always this one. Of course, CBD stones, cystic bloat, all these are possible. And fistula genostomy never mentioned. It is a rare surgery.
No, because
Exceptional situations, maybe you do. Yeah. Pradeep sir.
Yeah, I think Ravi, a lot of scope for improvement. I think, yeah, this is a straightforward case, and this is a very common case for exams. I think you can't afford to, and it's a straightforward. It's nothing unusual which the examiners have asked you. I think you had a lot of hiccups in answering those questions. I think a lot of improvement. You have to go again. You have to get back, and I'm sure you'll improve your performance. Um, I think we'll have other faculty here, Dr. Shastri, TD, Professor Kapoor.
Yeah, Ravi, obviously it's not your day today. Your clinical judgment did not appear sound at any stage of your discussion, right from the diagnostic options after history, the first imaging investigation, the interpretation of albumin, MRCP, and the way you jumped to a fistula and tracheostomy. These things left much to be desired. You need to show, focus on the interpretation at every stage, prioritize the issues, and get to various treatment options. I think you have a lot of work to do.
TD.
Morning, Pradeep. VK Kapoor.
Good morning, sir. Good morning, sir.
So in a patient with a post-cholecystectomy problem, pre-cholecystectomy history is very, very important. Not because you want to find out how and why the injury occurred, but main purpose is to rule out the presence of a missed CBD stone. You have to remember that the commonest cause of post-cholecystectomy pain and jaundice is still CBD stone, not bile duct injury. Also, here, because there was obvious bile leak, you have to know whether there is a CBD stone which has caused a cystic duct stump blowout. Because if that is the reason or the cause, then an early endoscopic intervention is required. So that is why pre-cholecystectomy history, LFT and ultrasound findings need to be reviewed. The most important thing in the management of bile duct injury is to drain a collection. So the first aim is to find out whether there is a collection or not. And that can be done with ultrasound, CT or MRI. And if there is a collection, it has to be drained. The second step in the management of an acute bile duct injury is to drain the bile duct so that the ongoing bile leak can be reduced and then finally stop. For that, you have to find out whether biliary enteric continuity is there or not. The ways to find out are, number one, clinical, as you did mention, stool color, but it is not very accurate. Stool may be colored if there is an internal fistula after some time, and stool may not be colored even if the ductal continuity is there. If it is a large output fistula, everything is coming out, nothing is going down. But yes, it is a good indicator. Next is MRCP. Then you didn't at all mention isotope scintigraphy, although we don't do it very frequently now, but it is a good method to find out if the biliary ductal continuity is there. And last, of course, is endoscopic ERCP. Biloma is not a clinical diagnosis. Biloma is a radiological diagnosis. A patient with bile duct injury may have features of sepsis, fever, and other symptoms. And then it could be either because of cholangitis or it could be because of a bile collection which has got infected. So clinical diagnosis should be intra-abdominal infection or sepsis, not biloma. Biloma is a term used for radiological diagnosis. After some time, when there is bile coming out either through the drain or through a PCD which has been placed, it is called an external biliary fistula. External biliary fistula can be controlled or uncontrolled. Uncontrolled means that bile is coming not only through the drain or PCD, but through the wound also, either the incision or the port side, or if the patient has sepsis, or if imaging shows collection. If none of these is present, it is only bile coming out of the drain with no collection, no sepsis. That is what is a controlled external biliary fistula. That is what is the ultimate aim of management of an acute bile duct injury, that you want to convert it into a controlled external biliary fistula. You just read out the reports of hemogram and LFT. That is not done. We can also read it. You have to give your interpretation. Twice you were asked, what does it suggest? And still you kept on saying INR is abnormal, bilirubin is high, hemoglobin is low. No, that is not the answer. Answer is that the hemogram suggests that the patient has sepsis. The LFT suggests that there is some coagulopathy. That is what the answer should be. In bile duct injury, in the acute phase, between CT and MRI, most of us would prefer an MR for multiple reasons. One, many of these or most of these patients are young. They are women. We don't want to expose them to high radiation. But more important than that is that MR, especially when combined with MRC and MRA, gives you all the information which you want and which CT will give you. You want to see if there is a collection. You want to see if the ductal continuity is there. And if you are thinking of an early repair, you want to see whether there is a vascular injury or not. So all this information can be obtained by an MR. The only problem is that if there is a collection, then that will overlap the biliary system. So before you do an MR, you have to be sure that there is no collection, which a good ultrasound should be able to delineate, because you have to drain the collection before you do the MR. So students, if you want to read more about the principles of management of bile duct injury and then external biliary fistula, there are several other issues, timing of repair and all, and biliary stricture, please send me a mail, vkkapoor.india@gmail.com, write BDI in the subject of the mail. I will send you some of our publications from SGPGI, which describe the philosophy of management of these injuries. Thank you. Thank you, Pradeep.
Thank you, sir. TD, any comments?
Yes, sir. Good morning. So my most of the points already have been made. My only comment would be that resident Dr. Ravi, you are not even able to take the hint from the Dr. Patta Radhakrishnan and everybody hinting towards MRCP doing before sending a patient back once you have admitted a patient and you are finding bile coming from the drain, means there is a biliary fistula. But after managing the fistula, when you are sending patient, one has to have a roadmap. What type of injury is there? And he is talking about ERCP repeatedly, but not even thinking about MRCP. It seems that MRCP he has not seen being done for the bile duct injury. It is true that if there is a collection, it won't be very informative, but once you have managed your patient earlier acute bile duct injury and have done the collection, you have an ultrasound where there is no collection and clinical scenario of the patient doesn't point toward the collection, then before sending, not that you do in acute condition, before sending back, we do isotropy scanning, but many centers don't do, we routinely do. Then you can do an MRCP, and even now there are dynamic MR and so many information can be achieved, and very select group of patient would be fit for the endoscopic management. And that care can be taken off within 2 weeks of the surgery, then endoscopy can do it. But if there is no communication on MRCP or isotropy scan, then ERCP is of no use and unnecessary. All the 5%, almost 5% complication can take place. We have seen patient coming with acute severe pancreatitis, and we were managing acute pancreatitis and biliary injury simultaneously. So other than most of the comments have been made, but it's very important to understand the way bile duct injury has to be managed, and stepwise one has to learn. So that is what is my comment and about this thing. Then he talked about I will do for surgery. Surgery also without having last MRCP. When you ask for the MRCP, then we could see that there is a block. Otherwise, earlier MRCP was showing some communication. So at that stage, saying that I will do hepatico in undilated system, and where you are probably able to see the bile duct going down. So that which is not the proper answer to my mind. Thank you, sir.
So if there are no comments, can we wind up Radhakrishna and Jeswanth? Yeah. Thank you, Radhakrishna. Thank you, Jeswanth. Thank you, Shabeer Ali, and thank you, Ravi, for anyway chipping in at the last minute. I know you not prepared because you are not the main presenter. But anyway, okay. All the best, Ravi.
Thank you, sir.
Thank you, sir.